Please welcome moderators, Doctors Mark Mahan and Zarina Ali.
Good afternoon, everyone. Thank you for attending scientific session number 4 on peripheral nerve for the spine surgeon. Peripheral nerves, as we know, are important lesions that are important to understand when we're assessing any spinal or peripheral nerve pathology. And we're going to hear today a little bit about the crossover between the two. We'll also learn about some of the newest technologies and techniques to improve our diagnostic success and ease of surgical technique and outcomes.
And with that, I would like to invite to our stage Dr. Elias Rizk, talking about peripheral nerve stimulation.
Thank you for inviting me to this exciting peripheral nerves for the neurosurgeon and trying to introduce the new treatment that we have in peripheral nerve neurosurgery with peripheral nerve stimulation. I took this from Denny and Harrop, and this describes really well the purpose of doing these procedures. The regional anesthesia always works, provided you actually put it in the correct place and the right dose. And nowadays, more and more, peripheral nerve stimulation is becoming more of a clinical practice, and you can develop added adjunct to your practice in a short period of time, understanding how to do this. And this is not really a novel idea. In the first century AD, human beings tried to use torpedo fish to discharge and help patients with pain relief. But the idea of peripheral nerve stimulation is close to 1967 in its infancy. And these are the components of the peripheral nerve stimulation, and this is one of the first devices that were typically used. And you can see how rudimentary, and you'll see other iterations that we are currently using nowadays. But in order to understand peripheral nerve stimulation and use this in your practice, you really have to delve and understand the basics of this intervention. And it really relies on the minimal threshold to do the stimulation with the Rio base and the chronaxy, and how much length of time you need to stimulate to be able to induce an action potential. And that really translates into the variable types of stimulation that you'll get from sensory and motor nerves. Nerve stimulation nowadays is based on voltages and milliamps. Very rarely do we switch with the increase in frequency, and the higher the frequency rates that you provide for the patient, you can create more discomfort. The other idea that you need to be familiar with is the close proximity of the stimulation to the actual nerve. And this is Coulomb's law that shows that the closer you are, the more effective stimulation that you will have. And that leads to the second segue, which is the type of stimulation and the positive and negative charges. And the more you have positive charges next to the nerves, the more appropriate stimulation you will get. And then the dispersion of the charges, especially with the placement of the leads and the type of leads, really varies the type of responses. So you really need to have leads that are developed and currently being in practice to hone down the stimulation as close as proximity as possible. Which brings in the case of understanding how to use the ultrasound. The more you understand how ultrasound works, the more you incorporate it into your practice, the better of a peripheral nerve stimulation placement you will have. And you'll see that peripheral nerve stimulation relies on understanding how the ultrasound works with the signal intensity and the frequency that usually develops into the types of probes that you will be using in order to be able to place safely those devices. So the higher the frequency, the improved resolution, but the depth of penetration is not that ideal. On the other side, the lower frequency, you will get a poorer resolution, but you're able to get into deeper penetrating tissues. For example, the sciatic nerve is way harder to find, and that is a helpful understanding to switch between probes. The ultrasound and placement of the gel also to insulate and be able to achieve better images is key. And the approach into the nerve, so you can come in as in plane or out of plane, which translate to advantages and disadvantages, and you can switch things around based on your familiarity and the placement of the nerve or the placement of the nerve stimulation. And there's nowadays two types of nerve stimulation. The temporary nerve stimulators, the major player in the field is Sprint, where you can put this device for about 60 days, and the patients typically have very good responses, but about 15 to 20% of them typically fail in the long run, and they transition to chronic peripheral nerve stimulators. They do have a higher rate of breakages, and they tend to leave some hardware behind when you remove them at 60 days, so that can be an issue for MRI imaging down the road. And these are the other alternatives. One of them is the BioNest stimulator here that you see, which is completely under the skin. The stimulator is a sticker with a battery on top that's rechargeable and controlled by the patient's iPhone. There's other alternatives like the Nalu and the Stim Wave. The Nalu is MRI safe, and the battery of life is way longer. The Stim Wave has a little bit more suited for a combined spinal cord stimulator and peripheral nerve stimulator. The complications of these devices is fairly low. One of the drawbacks of BioNest is inability to obtain an MRI within inches. And the courses that are provided actually makes the placement easier and more safer. So there's lots of potential resources to do those techniques on fresh cadavers. The data in acute management has been very promising, and also in the chronic pain management patients with very high responses. But at the same time, these are case series and not really clinical trials. But the momentum is really pushing forward with many, many new publications in that field. And the pain management data and the chronic shoulder pain, chronic knee pain, neuroma pain, and chronic pain management and headaches is really, really showing a lot of promise. And on the other side, too, you can get a decent reimbursement with the temporary trials that you can do in the clinic. So you can put temporary stimulators in the clinic and get reimbursement for that. And also on the operative side, these can be highly rewarding procedures that you can finish in 10 to 15 minutes if you're very good at ultrasound, and carry on and do several of those a day. Yes, the data is really promising in this treatment option, but really need to do better, just like the NeuroPoint Alliance, and come up with registries to show the case and try to enable us to help patients in the long run. Thank you.